Hello, folks. Thank you so much for joining me today. My name is Dana Brown, and I'm the Associate Director of Risk Adjustment for MRA. Here today to talk with you about HCC coding. Actually, this presentation is a pretty good introduction to HCC coding. We will get into some details of some of the things, um, and I hope you enjoy it. All right. First of all, this is a little presenter's bio about myself. It gives a little bit of background. I've been in the coding industry since 1983. I was the former founder of RMC, which was acquired by MRA in earlier this year in 22. Uh, I love HCC coding. It's one of my favorite things. I really started my career out as a DRG expert, but love HCC coding. So a little bit more about me. This is our disclaimer just in here to say, we did our very best. I feel like it's an excellent presentation. However, there's always opportunity for errors. So if you have any questions or something doesn't quite feel right, please feel free to reach out to me. And again, apologize if there's any errors. Please do let us know. So today, this is our agenda. Today, we're going to talk about the following. First is, what is risk adjustment? Secondly, we'll talk about the Medicare Advantage Risk Adjustment Program, as well as the ACA, also known as Obamacare. We'll talk about how does HCC coding work, look at documentation coding guidelines as they affect HCC coding. We're going to do what we call focus on correct coding, which everybody does, right? But that's really big in HCC as well. And we'll also lastly have some clinical documentation improvement tips. All right, moving on. So, what is risk adjustment? Risk adjustment was created initially with the goal of keeping patients healthy. And CMS, HHS pays more to health plans to treat sick patients. So basically, your goal is to keep patients healthy, but for those that you treat that are really sick, your payments will be adjusted to accommodate payment for those increased burden of illness. So how it works is a patient will elect to join a Medicare Advantage or an ACA program through a specific health plan. Uh, Almost all health plans in the U.S. now have them, but they have Medicare Advantage as like a sideline that the patients can elect to join. The health plans will receive funds annually to take care of patients for an entire calendar year. They'll receive monthly payments to do that. Payments to the health plan are based on the illness burden, which are chronic conditions and diagnoses. Kind of talked about that above, but depending on how sick the patients are, they may or may not get more money. It's not also, like fee-for-service Medicare, you get paid for every time you see a patient. It's not like that. It's not quantity of service, it's overall the patient's profile, how sick they are. So if there's a greater disease burden, it will equal greater revenue. So if they have a lot of things going on, they'll get more revenue. But in theory, it's because it costs more to take care of those patients with a lot of issues, right? So that's the theory on that. Health plans, in turn, pay providers for the care they provide to the patients. So in risk adjustment, Medicare Advantage, super successful. It's been a really well-ran program. It's been really good benefits for the patients, providers, etc. It's been such a popular plan that when they decided to develop the ACA or Obamacare plans, it was the model program that Medicare Advantage was, the ACA was modeled after. So we have common payers for Medicare Advantage risk adjustment programs: Blue Cross, Providence Healthcare, MODA, Kaiser, United Healthcare. All the big ones have some Medicare Advantage program. Most also have the ACA programs, but not all. Some health plans, in turn, share the increased revenue with its providers and IPA associations. That's called in your contracting, and for those of you that are involved in the contracting, shared risk, okay? So they'll sliding scale depending on what the numbers look like. The big thing, as in anything coding related, is education for providers. That's the key to all of this. Providers need to understand the programs, why it's important. It's important to document for the patient's well-being, but also, for the health plans too. So kind of already talked a bit about it, but here's a little bit more details on the two main models. The first on the left is the CMS Medicare Advantage program. The one on the right is the HHS/ACA, also commercial program. The first one on the left, we'll kind of go down that column first for the Medicare Advantage. It was developed by CMS for the risk adjustment of the Medicare Advantage program, which is called Medicare Part C. CMS also developed a CMS RX HCC model for risk adjustment of the Medicare Part D population. Again, that's the pharmacy, right? Part D. And of course, the population for this group of patients is the Medicare age, so it's over age 65, and also those with disabilities. On the right-hand side, the HHS ACA commercial was developed by the Department of Health and Human Services, or HHS. It was designed for commercial payer population, and it includes all ages. So we're going to have moms and babies in here too. A little bit of facts about both Medicare and ACA. First, for MA facts, there's about 22 million people on the Medicare Advantage plans nationwide. Okay, so 22 million people, Medicare age, are enrolled in a Medicare Advantage plan. Nationally, 34% of all Medicare beneficiaries are on an MA plan. And in the state of Oregon, 44% of Oregon Medicare beneficiaries are enrolled in a Medicare Advantage plan. I believe one reason for that is Oregon was quick to some of the big payers in Oregon, Kaiser Permanente, Providence Health Plan. They were really good as far as getting the word out to patients about enrollment. So I think that is why that number is so high. ACA facts, we have about 13.7 million people nationally are enrolled in an ACA insurance plan. 11.4 million were enrolled through marketplace plans. And Medicaid facts for ACA really is dependent upon state eligibility guidelines. Not all states have adopted the ACA to offer benefits to Medicaid participants. So the future of risk adjustment is bright. The risk adjustment enrollments have increased tenfold in 10 years. That's a lot, right, folks? Tenfold in 10 years is a lot. The model plan, it is Medicare, the Medicare Advantage plan, as we discussed before, is the model plan for ACA. Health plans are getting smarter. They're understanding how Medicare Advantage works in their ACA also. Unfortunately, I swear anything with coding involved, coding is any part of a reimbursement, there's always fraud, okay? Intentional or unintentional, there's always fraud. So for you coders, managers, etc. out there, compliance is the key, right? In all the coding that we do. The big thing that we've always said for years is code it right. We don't want things up-coded. We don't want you intentionally down-coding either. Just code it right. A little bit more about the model, the risk adjustment model. So again, payments are made to the health plan based on the illness burden, right, that we talked about. That illness burden comes from the HCC codes, hierarchical condition codes. Patients are assigned HCC codes based upon their ICD-10 diagnosis codes submitted on claims throughout the year. These are all claims, all providers, hospitals, etc. Now, one thing to keep in mind is not every diagnosis code will turn into an HCC. We'll talk about that in a minute. But the diagnosis codes create or map to an HCC, which will together give us the patient's profile of all their conditions, which will create the risk score, okay, which is the illness burden. More to come. It'll all make sense as we go through. Overall, there is 86 HCCs in the MA model, and 127 HCCs in the ACA model. For MA disease groups in HCCs, there are 9,700 ICD-10 codes in the CMS HCC model, and they are divided into disease groups or hierarchical conditions. Examples that you'll see in this group are infections, diabetes, substance abuse, neoplasms, blood disorders, lung diseases, artificial openings, and ostomies too. The model is not all inclusive, so many diseases are not included, okay? Only chronic conditions that really can affect the patient. This just gives you a snapshot of those. The current version for Medicare Advantage is called the V24 model. So the V24 model includes, again, there's 9,700 ICD-10 codes that map to one or more of the 86 HCCs. And in this list, you can kind of see these are the top 10 most common HCCs by volume, okay? So the most common is number 1 is diabetes without complication. We probably could have guessed that. The next one in the most common will be breast, prostate, and other cancers and tumors, HCC 12. There's a lot of patients, unfortunately, that fall into that HCC. Third one is diabetes with chronic complications. It's HCC 18. Then we have seizure disorders, arrhythmias, CHF, going on down the line, significant endocrine metabolic disorders, COPD, major depression, bipolar and paranoid disorders, and lastly, morbid obesity. So again, this is just the top 10. Okay, we have a lot of HCCs. We have 86 HCC groups, but this is just the top 10. And again, for Medicare Advantage. So in the model, most acute conditions are not included. Things like appendicitis, wrist fracture, those kinds of things. They're acute. I think, in my opinion, the theory is the patients come in once, they're treated, they're released, and that's pretty much, they're done with it. It isn't a chronic condition that hangs on. However, some acute conditions are in the model. Things like hip fracture, acute stroke, acute MI, those things are included, okay? But you can see that those would have implications for future care, right? So that's, I believe, the difference between the acute conditions up above and the ones below, if they have implications for future care. Okay, so we want to look at in Medicare Advantage, there are conditions that as an auditor, I have seen and my staff have seen missed quite a bit. And below is a list of the frequently overlooked conditions. We have things, and these are big ones, right? So things like CHF, angina, AFib, COPD, compression fracture, seizure disorder, history of alcoholism, psychosis, rheumatoid arthritis, polymyalgia rheumatica, history of amputations, a big one, transplant status, and dialysis status are all frequently overlooked in MA. These, along with at the bottom there, you'll see ACAs plus asthma. Asthma is a very common one that we see a lot in the ACA patient population that has not been captured. So please keep those in mind. Those are all big ones. Okay, sorry about that. These are some examples of some of the Medicare Advantage HCC examples. So HCC1, in this category, you'll see patients with HIV, AIDS, those kinds of diagnosis codes will map to HCC1. HCC 8 through 12, 46, and 48, this is the malignant neoplasm category. So you will see patients with malignant neoplasms that map to these HCCs. And I would venture to guess pretty much all malignant neoplasms are going to map. Then we have diabetes with chronic complications. It's HC 17 or 18. Depends on what the chronic complication is. Some will map to HC 17, some will go to 18. Then we have HCC 19, diabetes without complications. That's just your E11.9. Will go to HCC 19. And and so on. Then we have osteonecrosis goes to 39. Alcohol abuse, some drug abuse, independence go to HCC 54, 55. CHF goes to HCC 85, and some other pulmonary and cardiac related conditions will also map to 85. Again, this list is not comprehensive, okay? This just gives you a snapshot. All right, this is what I call our mapping tool. This is just a snippet. Our mapping tool at MRA that we use for our audits, we have used all kinds of things, but to be quite honest, the printed out Excel or electronic version is great. You don't need anything fancy to do a good job at risk adjustment. You just need to do it. But this is a copy of the mapping tool, and you could see it's on line 1700. I think when we print it, it's probably about an inch thick and double-sided, so it's a pretty large document, but it lists out all the diagnosis codes if they map or not. So you can see here E11-9 is regular diabetes without complication. It maps to HCC 19. Whereas you can see up here, diabetes with other specified complication or with unspecified complication goes to HCC 18. And then you see diabetes with hyperosmolarity without non-ketotic hyperglycemic hyperosmolar coma goes to HCC 17. So you can kind of see the difference there. Again, this is just a snippet of a large document, but it gives you an idea of if it maps or not. If it doesn't map, this column that has all the numbers in it, the 18, 18, 19, 17, 17, those will all be blank, okay? And it'll say no in the next column. So hopefully you find that interesting. Here's another one that I found, and it's a sample mapping. I put the reference in the reference thing. It's number 6. I just thought it was really cool to see it. But what it's telling you is that here, all these codes map to these HCCs, and the category 1 here is, what HCC they go to. So as you can see, the first line is B20, B97.35, and Z21, all map to the HIV AIDS category, which is HCC1. Okay? See that to HIV with this HCC1. So, and further on down here, you can see all the cancers, what the actual codes are, that map to that HCC and gives you more information. The other part on here that I think is interesting and nice to see is this disease hierarchy. It is the last column in this document. And the disease hierarchy, we're going to talk in a minute about that, but it's kind of cool. It gives you that too. So, hierarchy, trumping, call it all kinds of different things, but this is it. And this is how it works, okay? So, we have on the column on the left is the HCC, and the middle column is the category for this HCC, okay? And on the right column is, ones that you're going to want to drop or delete if you're trying to figure out your risk score. So what this means, here we have HCC 8 is metastatic cancer and acute leukemia, okay? And this says, then you drop HCCs listed in this column. These are HCCs 9, 10, 11, and 12 right here, right? So you're going to drop those codes if you're going to be coding HCC 8. In the model, you can only obtain one HCC for those like HCCs, okay? So these are all the diabetes ones, right? The 8, 9, 10, 11, 12 are all diabetes. So that's why cancer. These are all the cancer ones. So you're only going to get the highest paying HCC, and that's why it's having you drop all these. The highest paying in the model in these categories, in like the cancer category, the highest paying HCC is always the lowest one. So that's why 8, say this patient has a ton of cancers, which is so sad, but happens, you would drop all these. You're not going to get reimbursement on every single one. You're only going to get it on HCC 8. Now let's look at diabetes. Here's HCC 17 down here, and it's diabetes with acute complications. 17 is the highest HCC for diabetes, the highest paying, okay? But we've also got HCC 18 and 19, our diabetes ones, right? So in this model, if you have a 17 and 18 and a 19 reported, you're only going to get reimbursement on the 17. So it's going to drop 18 and 19. Okay, so this just gives you a little bit of a snippet of how the program works financially. I think it's really interesting to see that. Also, from an auditor's perspective, if you have an HCC 17 already reported, you're not going to add HCC 19 for generic diabetes because you've already got HCC 17 reported. So I think from an auditor's perspective, it's very important to understand the hierarchy and the trumping. All right. So a little bit more about the ACA versus the MA model. The ACA has many more diagnosis codes than MA, of course, because you have OB and we have newborn, right? HCC's not in the ACA. You won't find HCCs for obesity or BMI, for AKI, for alcohol and substance abuse. Although I think that will be changing, but you will not have HCCs and ACA for those three. But again, frequently found, like we talked about earlier, is asthma. That is something that's found in the ACA model that is not in the MA model. All right, so this is a snippet of all the a portion of the ACA HCCs. And it gives United with HIV. We have low birth weight, postpartum. Those are things, of course, we don't see in MA. Then we have transplant, artificial openings, dependence on machines. This would be like a ventilator. That is also in MA. A lot of Z codes in here too. So, and again, this is not all inclusive. This is just give you a snapshot of it. So let's talk about how the model works. And we're primarily speaking just to MA, but we're going to look at this real quickly. It's similar in ACA. So what the government came up with for this model was that they are going to give each county in the U.S. a county rate, okay? So here's your county rates, part of it. The county rate, and this is where the patients live, okay, is between $800 and $1,200. It varies across the country. For Marion County, Oregon, the Marion County rate is $906.91. You will also get a rate for your demographics. They take into account your age, sex, location, if they're eligible for Medicare or not, okay? Then they look at the HCC RAF score. So each HCC has what's called a RAF score, risk adjustment factor. Think of it like a DRG weight, how each DRG has its own weight. Each HCC has its own RAF score. So that's part of the calculation as well. So what we do is we take our county rate times the demographic rate plus your RAF score equals your monthly capitation rate. That's what you will be getting, the health plan will be getting every month to take care of these patients. So let's talk about a real patient, maybe not really real, but close enough. We're going to talk about Ruby May. She lives in Silverton, Oregon. According to CMS spreadsheet, Marion County has a county rate of $906.91. She is 94 years old, still lives at home, and is eligible for Medicare. Her demographic conversion factor is 0.85. She also has uncomplicated diabetes. Its weight is 0.18. Stable angina, the weight for that is 0.14. And schizophrenia, the RAF score for that is 0.61, the weight. So we're going to 906.91 times 1.78. The 1.78 is her demographic conversion factor is 85, plus the weights for each of the HCCs reported above: the diabetes, stable angina, and the schizophrenia. Those are all the weights, okay? So this times 906.91 times 1.78 is 1614.30. That's $16 and, excuse me, $1,614.30 per month is the monthly capitation rate. So the basics of the reimbursement model is that each patient has an annual payment, which again is the county and demographic rate. HCC payments are additive. Each HCC has an individual payment which adds together to equal a RAF score, okay? So that is what we talked about before, right? We get the demographic, we get the county, and we get the HCC scores, or the risk adjustment factor. Then for this patient, we have the trumping, the hierarchy that goes into play. The patients are paid, excuse me, the hierarchy trumping affects which HCCs are paid on a patient. Like if they have 3 diabetes levels, they will only be paid on the highest diabetes, okay? They're also paid prospectively. Diseases captured in 2021 are paid in 2022. Now, there's some big changes in the works, okay? So for payment year 2021, 25% of the risk score is using the 2017 CMS HCC model, using diagnoses from the RAPS and the FFF, the fee-for-service. Then 75% of the risk score calculated with the 2020 CMS HCC model, using diagnoses from encounter data, RAPS inpatient, and fee-for-service. For payment year 22, it's changing even more. It's going to be based on the 2020 CMS HCC model, as required by the 21st Century Cures Act, adding in variables that count conditions in the risk adjustment model and includes payment for mental health, substance abuse disorders, and CKD, which is a good thing. Different from 21, where 75% of the risk scores were calculated using the 2020 CMS model and 25% risk score calculated using the older model, which we talked about above. There are 2 risk segments. We've got the community model, which is the majority of Medicare beneficiaries, and we also have the institutional model, which are beneficiaries living in nursing homes or assisted living facilities. All right, so moving on. For ICD, we're going to talk about coding now. And again, as we kind of mentioned before, you know, the HCCs are based upon the coding, right, that is done throughout the year. But each diagnosis code must be documented and reported to be calculated, but it only has to be reported once annually to be included in the risk scoring, but only once, okay? We want to make sure that it's valid, but it only has to be reported once. So as an auditor, we do see problems in ICD-10 coding. A lot of times we see physician offices do not always code to the highest level of specificity or include all eligible diagnosis codes on the claim. The average physician claim includes 1.6 diagnosis codes per claim. This is low, folks. We know a lot of these patients have a lot more things going on than that. The things that we see are like chronic conditions are often not coded if the patient is being seen for another complaint, okay? Chronic conditions are being managed by specialists, so the PCP doesn't code them. These can be coded, okay, if they refer the patient to a specialist or the specialist is managing. They just need to document that, and it is a codable condition for a PCP. We also see that coding guidelines just aren't followed, and it's a lot of times people aren't aware of what the coding guidelines are. So that is a big deal. We want to know, providers and coders need to be aware of diabetic manifestations that they can code. They're frequently overlooked. An example of this is we can code both the E11.22 for diabetic chronic kidney disease stage 3. It's HCC 18. But you can also code the N-code, the N18.3 for CKD stage 3. It's HCC 138. You can code both, and you should. Things, though, that we see that shouldn't be coded are historic conditions that are no longer under treatment. Like an old CVA, if the patient's had a CVA and they have no residuals, nothing going on, that needs to be coded, as old CVA, not as acute CVA. Also, history of cancers, if they're no longer under treatment, with a few exceptions, it should not be coded. Documentation is key, like in everything we do from a coding perspective. Accurate coding is dependent on clear and specific provider documentation of the patient's medical record. Done and done, okay? We've got to be able to see it in the chart to be able to code it, and we can't do creative coding and put things in that we don't see. We do need to code all documented conditions that exist at the time of the encounter and require or affect patient care, treatment, or management. And that's straight out of the ICD-10 official coding guidelines. And again, that's reference number 1. So, documentation requirements. For a document to be considered valid and to be used for coding and billing purposes, we want to make sure it includes the following. Must have a signature. If it's an electronic document, super cool, that's great, but it still needs to have an electronic signature. Also, it needs to have the date of the visit. It needs to be legible and with the patient's name. Not a lot, surprising how many times we don't see that. Now, below is just a snippet of what we call the acceptable physician specialty types. And this is I think it's for MA. I apologize. I put this in here. I don't really remember. I think it's just MA though. But this list is actually, it's more than an 8.5 by 11. It's much larger than this. If you would like a copy of it, please email me and I'll shoot it off to you. But you can see in here, a lot of provider types are in here. Chiropractors, all the different specialties. But some providers, are not... their billing for their services is not put into the risk adjustment data bank, so to speak. You can still bill for them, you can still get paid for them, but the diagnosis codes from a non-acceptable physician specialty won't be calculated in the risk adjustment score. All right, caution in EMRs, foe or friend. Okay, so for those of you that have been working in healthcare as long as I have, the transition from paper to electronic has been so great in so many ways, but so horrible in so many ways. One big one is the cut, copy, and paste. We see providers, doing this not appropriately. Organizations must have a policy in place for what is acceptable protocol for that. As a coder or an auditor, you need to be really wary of what is, cut, copy, and pasted. I saw once, I was auditing a chart and we looked at the whole year's worth of visits, right? So this morning, it said in the ER record, this morning, patient fell off their ladder and, they slipped and fell off the ladder and blah, blah, blah. A month later, patient seen in the ER this morning, fell off the ladder. The next visit, patient was seen this morning, fell off the ladder, and it obviously had been copied and pasted. And, we couldn't use that. You have to be super careful about that. Lastly, again, policies and procedures, we need to have those in place. Okay, moving on. We're going to be talking about focus on correct coding. These are just some generic stuff. Some of this will be new to you guys, but it's kind of an overview of the big things that we see in HCC coding. Okay, so number 1, big one, use the guidelines. Okay, some of you might be going, we don't really know what the guidelines are. That's totally cool. That's why I'm here. But we have national coding guidelines for ICD-10-CM, PCS, CPT. There are national coding guidelines that we must use. Now, for ICD-10, they are located in the front of your code book. If you don't have a real code book, you can Google it and you can find it, national coding guidelines. You do need to be cautious when you Google, but you can find it, and it's out there. So another thing, back to Google, careful in Googling. I mean, you can find the coding guidelines that way, but be very careful in what you do as far as Googling when you're coding. Just because something came from, say, the American Academy of whatever kind of provider does not mean that's correct. Okay, you want to make sure we have guidance from, the National Coding Guidelines, or for diagnosis coding, it must be in the coding clinic. Otherwise, it's not an official coding guideline. Okay, so coding clinic, that's the last little section here. It is published quarterly. It's part of National Coding Guidelines. There's a section for Q&A, which is awesome. If you have questions that you can't figure it out, you can email them. I think you get a certain amount with your subscription, and then there's a fee. But it's just a wealth of information. It's been coding it's been in existence as long as I've been coding, since like 1983. So it's great. It started off because of DRGs. There were so many questions about DRGs. So that's how Coding Clinic originally started. But it was made official per HIPAA when HIPAA came out. So we're going to talk about some specific diseases. The first one we're going to talk about is diabetes. So diabetes mellitus associated with manifestations, also known as diabetes with. Okay, this came out 2016. We had a new coding clinic that came out and said that, according to the official coding guidelines, coding and reporting, the term with means associated with or due to when it appears in a code title, the alphabetic index, or in an instructional note in the tabular list. And this is how it's meant to be interpreted when assigning codes for diabetes with associated manifestations or conditions. The classification assumes a cause and effect relationship between diabetes and certain diseases of the kidneys, nerves, and circulatory system. Okay, so you really want to look in your book. If it's in the index, diabetes with, you can combine those and have a combination code, but also code the associated manifestation. So it used to be the doctors had to say diabetes with CKD to combine the codes. Okay, don't have to do that anymore. Okay, let's go on. I think most everybody knows this one, but here's the coding clinic there at the bottom. It's See Coding Clinic first quarter 2016, page 11 for the full details. It's really an awesome guideline that came out. Totally makes sense and makes it a lot easier for coders to get the full clinical picture of the patient. Okay, so here's an example of the index. Diabetes with, and we have amyotrophy. I don't know if I said that right, but we have arthropathy. I can say that. The E11618. Okay, so if the patient has arthropathy and diabetes, you would want to code the E11.618, and also probably if you go to this code, it'll say code also the arthropathy. Maybe not, but it probably does. But this is how it's going to look. The width is going to be just like that in your index. Next slide. Here's some more. Here's another example. Those frequently overlooked are diabetes with nephropathy. We do want to code the CKD also. Okay. Diabetes with foot ulcer. You would want to code the foot ulcer. It's HCC 18, as well as your L code, which is HCC 161. Now, one thing that's interesting, diabetes type 2 with diabetic peripheral angiopathy without gangrene is HCC 108. But it tells you to also code the I-73.9, which is the peripheral angiopathy. Coincidentally, it also maps to HCC 108. But regardless, in that situation, you would still want to report both codes because it tells you to report both codes. Okay? Neoplasms. Malignant neoplasms are to be coded when the patient is receiving any care or has meat. Okay? If the patient is refusing treatment, the provider may still be addressing the condition and the appropriate neoplasm code should be assigned. So let's talk about this. Caution, be careful when coding metastatic neoplasms, as documentation may not be clear as to whether it's the primary or secondary site. Do investigate whether it is metastatic to the breast, which would be secondary, or metastatic from the breast, which would make it primary. And this is important for coding accuracy, but also because there's different HCCs between metastatic and primary neoplasm. There we have HCC 10 and HCC 12. Also, caution when assigning a code for history of malignant neoplasm. If the patient is receiving treatment like chemo for a neoplasm that's been excised, you definitely can assign a code, the C00 through the D49, okay? But if the patient is no longer receiving treatment, do assign a personal history code, which is the Z code, category Z85, which is not an HCC. Okay, now breast cancer is a little trickier. So when to code breast cancer? You do want to code it, of course, if the patient is receiving active treatment, of course. If the breast cancer has reoccurred, if the patient elects to not treat, okay, if they know they have breast cancer and it's well documented by the provider, but they don't want to treat, or if they've chosen palliative care, then you could still code it. All right, coding focus, alcohol and drug abuse, and this is for ACA. You want to code what is documented and documented accurately. Dependent is an HCC, non-dependent is not an HCC, alcoholism is an HCC, okay? Without documentation, coder must default to non-dependent, which is not an HCC. So if they call it alcoholism, though, the index will map you to dependent. So that's how that gets to be an HCC. Frequently, but in error, we'll see F10.20, which is alcohol dependence uncomplicated, which is HCC 55 is coded, but dependence is not stated. They just say alcohol use, alcohol abuse, but they're not calling it dependence. Okay, so you got to be super careful on that one. Okay, this one, if a patient has a history of addiction or dependence and the document supports diagnosis, code the dependence disorder to in remission. Okay, so we have alcohol dependence in remission, cannabis dependence in remission, both HCC 55. All right, this is a myelodysplastic syndrome, which is for both MA and ACA. We see this from time to time that there's confusion in coding myelodysplastic syndrome, D46.9, which is a blood and marrow disease that occurs in the bone marrow, does not make enough healthy blood cells, and marrow cells are damaged. Whereas myelodysplasia of the spinal cord is a congenital anomaly encoded at Q06.1. As you can tell, these are two totally different diseases. And you want to make sure that as a coder, as an auditor, that you don't make any assumptions. You really need to read the provider's documentation well on this. Here's some information regarding the myelodysplastic syndrome. If the patient is receiving care from either hematologist or oncologist, that would qualify. Observation of blood cell counts, transfusion and chelation therapy, erythropoiesis, stimulating agents, your ESAs and other growth factors, your anti-thymocyte globulin therapy, the ATG, any drug therapies, I can't pronounce those drugs, chemotherapy, the allogenic stem cell transplantation, and clinical trials. Any of those would be potential meat to support your coding of myelodysplastic syndrome versus of the spinal column. Totally different things. Totally different things. Okay, now let's talk about lymphoma. In lymphoma, patients who are in remission are still considered to have lymphoma and should be assigned with the appropriate code from C81 through C88. However, if history of is documented, assign a Z code. HCC Coding Clinic from 1992 second quarter, page 3. There was a recent coding clinic that came out third quarter 2022 that, I'm sorry, at this time I haven't had a chance to review it, but it might impact that. So please be aware that it's either lymphoma or leukemia that will be impactful to everyone's coding. And I apologize for not having that in this. You can email me if you'd like more info. And here we go, morbid obesity and BMI. And again, this is only in the MA, it's not in the ACA, but per the coding guidelines, a non-provider, meaning an RN or MA, may document the BMI, but to report the BMI as a secondary diagnosis, a related diagnosis of overweight, obesity, morbid obesity must be documented by the provider. For an example, such as this, in the vital signs, it's documented 42.1. And the provider documentation states the patient is overweight. You can code the overweight, the E66.3, which is no HCC, but that allows you to code the Z68.41, which is HCC 22. Okay, so you want to make sure you have both codes if you are coding the BMI. Depression's a big one, right? Depression NOS is coded F32.9. It's not an HCC, but depression and anxiety is coded F41.8, no HCC. But potentially, this is an opportunity to improve the documentation. Providers need to, only document what is appropriate. But F33.0 is major depressive disorder recurrent, which is the code for recurrent episodes of depressive reaction and likely the case for instances when depression NOS is documented. I think for here, we want to make sure the providers are educated to document the conditions clearly. Too many times we'll just see depression NOS, and there's a lot more going on with that patient if they're coming in every month, medication checks, those kinds of things. It's a good opportunity to query the provider if it can be further clarified. Of course, not every depression is going to be major depressive disorder recurrent, so make sure that they're queried and given the opportunity to further clarify if appropriate. Okay, let's talk about CKD. It's a HCC in both MA and ACA. It is often a complication of another serious condition like diabetes or hypertensive heart disease. In ICD-10, these complications should be captured with a combination code, okay? So you want to be sure to review the index and tabular carefully. So here is a list of the CKD. Sorry about that. ICD-10 classifies CKD based on severity. The severity of the CKD is designated by stages 1 through 5. Okay, so here's CKD stage 1, 2, 3, 4, 5, and end-stage renal disease, which is typically the patients on dialysis, maybe that code. So review the documentation for dialysis treatment. Frequently, these codes are not assigned. If the patient is on dialysis, you can code the Z99.2, which is dependence on renal dialysis, HCC 134. And conversely, if the patients are not wanting to do dialysis, you can do patients non-compliance with renal dialysis, okay? So it's HCC 134. Okay, now let's talk about focus on correct coding. CVAs is something which we see documented a lot. Acute CVA when it's not actually an acute CVA. So you want to make sure that it is being captured appropriately. Often CVA and stroke are used interchangeably. CVA should be coded if it's acute. It just happened. Acute CVA codes rarely occur in the outpatient setting unless the patient develops a CVA while in the clinic and is transferred to the hospital for inpatient care. You might see that. I've seen that once in all my years, but you might see that. But I would recommend extreme caution in coding acute CVA in the outpatient setting. Okay, when you do code in active stroke or CVA, it is important to code it appropriately. Code it to the type of event, whether it was hemorrhagic, embolic, where exactly it occurred, if it's with an infarction or without. Those all make a big deal, and it needs to be quality coding, so it's important to capture those. Documentation of a history of stroke without neurologic deficits codes to Z86.73, personal history of TIA and cerebral infarction without residual deficits. And that's no HCC. All right, so let's talk about sequela of a CVA. I-69 category is the category for sequela of cerebrovascular disease. Codes are used for neurologic deficits which are caused by the CVA or diseases classifiable I-60 through I-67. So we do have common sequela, right, of a CVA, which is hemiplegia or hemiparesis or monoplegia, which does require dominance of an affected side. If the documentation does not indicate dominance, select a code based on the following. If it's the left side is affected, then the default is non-dominant. The right side is affected, the default is dominant. If they're ambidextrous patient, default is dominant. I always forget that, so that's a good reminder for all of us. All right, and this is a really important coding clinic from 2015 for the coding of sequela of a CVA, specifically unilateral weakness. So for unilateral weakness that is clearly documented as being associated with a stroke, is considered synonymous with hemiparesis or hemiplegia. Example patient is history of left hemispheric stroke. Patient has right-sided weakness, which codes to I-69.351. The patient with a history of CVA and hemiparesis, together, this makes them classified as late effect sequela of a CVA stroke that is appropriate to category I-69. Okay? Keep in mind that hemiplegia is the paralysis of one side of the body, whereas hemiparesis is the weakness of one side of the body. Documentation must state hemiplegia or hemiparesis to assign a code from G81. Okay, they must specifically state that. Now let's talk about pulmonary embolisms. Pulmonary embolisms may be an acute event or chronic condition, right? We know that. It can go on for quite some time, the treatment, not based on time frame, but on provider documentation. They do use coding for anticoagulation use. You want to make sure you code that. Patient may be treated with anticoagulant to treat chronic pulmonary embolism, which is a HCC, or personal history of PE, which is not an HCC. It's important to review the documentation. This is one of the hardest things I think too in HCC world is to know exactly if it's a chronic PE or history of. Be sure to sign code the Z79.01 for long-term current use of anticoagulants if pertinent. That's important for code capture. It doesn't help us with HCC, but it's important for code capture. Another area that I think we need to address is PVD or PAD, peripheral vascular disease or peripheral artery disease. So PVD is a condition that results in reduced blood flow to the extremities. PAD is a more specific specific diagnosis for the same condition. PVD and PAD and intermittent claudication code to or index go to I-73.9, PVD, unspecified, which is HCC 108 and MA only. It also has an excludes note referring to atherosclerosis of the extremities. A little bit more on there. PAD caused by atherosclerosis of the extremities must be reported with codes that describe the etiology, the site, manifestation, complications, and below are some examples of that. I-70.2 219, atherosclerosis of native arteries and extremities with claudication. Unspecified extremity is 108. Also, if it's in the bypass graft of the left leg with ulceration of the thigh, and type 2 diabetes with diabetic peripheral angiopathy without gangrene. Okay, next we're going to talk about arrhythmias. There are many different types of arrhythmias, as you can see down here. The most important thing, we are kind of running out of time, so I apologize for that. The most important thing here is to make sure that you code as the providers are documented, okay? If they called a PSVT, code that. If they don't. Also, we have atrial fib and atrial flutter, which are very different things. You want to make sure you address those and code those appropriately. One thing I did want to bring to your attention were these two coding clinics on sick sinus syndrome with pacemaker. This is contrary to past coding clinics, so I want to bring it up. But when sick sinus syndrome is controlled with a pacemaker, you can code the sick sinus syndrome, okay, per these coding clinics. So please take a look at that. That's a big change for us and important for you to be aware of. Also, coding fractures. Fractures of the hip and femur can be captured as HCCs, but we want to make sure that we capture all the necessary information to make it a valid code, meaning the site, the laterality, the type of fracture, if it's displaced or not, closed or open, the Castillo classification if you can, and of course the encounter type, initial, subsequent, etc. I believe only initial is an HCC. And compression fractures is a big one too. We want to be really careful that we're coding them to, spontaneous or chronic, okay? Spontaneous is pathologic. Chronic equals a current fracture, okay? So healing or old compression fractures should be assigned a code from Z87.31, personal history of healed non-traumatic fracture, okay? So you got to be really careful on that. Okay, osteoporosis is another area you want to make sure that is involved a lot with patients with pathological fractures, but there must be documentation linking the conditions to each other. Never assume osteoporotic or pathologic fracture based upon the age of a patient. Okay, awesome. Well, thank you. In summary, coding must be representative of the patient's profile of care and treatment rendered for the whole entire document and/or year. Documentation is key. Do utilize and follow all national coding guidelines. That's super important, and I can't express that enough. National coding guidelines, coding clinic, utilize those as much as possible. Proper documentation and accurate coding will result in appropriate and compliant reimbursement. Thank you all so much for joining me here today. I really appreciate your time. I hope you learned some great little tidbits. And as always, if you have any questions at all, please email me at dbrown@mrahis.com. I would love to answer any questions you might have, forward you information, etc. So thank you again so much for joining me. I really appreciate it. Here is the reference slide. Please do let me know if you have any questions. Thank you so much.